introduce our first speaker. Is Aniruddha Agarwal, who is working now at the Cleveland Clinic in Abu Dhabi. And Annie has a huge experience in imaging. He's been working on this since his previous time in Chandigarh with Vishali, and will be talking to us about investigating the choroid imaging and how it helps in the diagnosis and monitoring. Thank you, Annie, for joining.
Greetings from Abu Dhabi. My name is Aniruddha Agarwal, and it's my pleasure to be here with you. And thank you, Team SOE, for this opportunity to present my topic on investigating the choroid imaging and how it helps in the diagnosis and monitoring. So at the outset, let me quickly go to my case. This is a patient who presents with a yellow lesion in the superior retina of the left eye. And one clue to the diagnosis here is that he's an Asian Indian male. And if you do further imaging with fluorescein angiography, you can see that the lesion is hyperfluorescent. And in the late phase, there is some leakage around the lesion. This is what we typically call as the tubercular multifocal choroiditis, as per the latest nomenclature classification by the Collaborative Ocular Tuberculosis Study Group. Multifocal choroiditis lesions with a phenotype similar to idiopathic multifocal choroiditis, which is similar to also the MPE and other phenotypes that do not resemble TB-SLC. On the other hand, tubercles are single or multiple small lesions with a central core and a surrounding rim of inflammation. This is another patient here, and you can see the disease is much more dramatic in this eye, and you have a yellow lesion which is surrounded by fluid. And on fluorescein angiography, there is nothing much in the initial phase. There is a hypo area. And in the late phase, there is intense leakage with subretinal fluid accumulation. Now, these are the patients who would benefit from choroidal imaging, as we see. And you can see that this diagnosis is very clear, especially if the patient is from endemic country for tuberculosis. And this is another patient who presents with a yellow lesion which is involving the center. And you can see that there is some fluid, but it's not so much like in the previous case. And the color is also not so intense yellow, it's dull. And you can see that this image, the wide field fluorescein angiography, shows you some leakage in the center and the disc is mildly hyperfluorescent. But if you look at the indocyanine green angiography, the ICG, which gives you the absolutely correct assessment of the choroid, you can see that there is a hypo area in the center, which is not so much evident on fluorescein angiography. The late phase ICG shows you this area much more clearly, and there is hypofluorescence suggestive of the choriocapillaries flow deficit. And this is a patient who has some subretinal fluid, but not so much as the previous case. But you can see in the subfoveal region, there is a large granuloma sitting right under the fovea. And this is a patient with sarcoidosis. So when we talk about choroidal imaging, one of the most important disease phenotype that benefits from choroidal imaging is choroidal granulomas. And as we see in the examples that I discussed, tuberculosis and sarcoidosis form two most important reasons why you can have choroidal granulomas. A choroidal granuloma due to TB is now called as a tuberculoma, and it usually presents as single, sometimes multiple lesions which are yellow, which have indistinct borders and surrounding fluid. And you can have rapid necrosis, exudation, and tissue destruction, and those cases are called as tubercular subretinal abscesses. These patients, the highlight of the clinical examination is that they may have significant retinal hemorrhages. Recently, we investigated these patients and looked at multimodal imaging clues to differentiate between tuberculomas and sarcoid choroidal granulomas. And we observed that EDI-OCT has a very important role in monitoring the choroidal lesions. We know that on EDI-OCT, you can look at the hypofluorescence in the deep choroid, and this is nothing but a full thickness choroidal granuloma with overlying choriocapillaries, ischemia, or thinning. So this particular patient that is illustrated on this slide had also a calcified mediastinal lymph node suggestive of sarcoidosis. And so EDI-OCT makes it very easy for us to follow up these patients longitudinally And you can see this patient, the panels above A, B, and C are at presentation, where you have a large granuloma. And towards the follow-up after treatment, you realize that the granuloma has decreased in the anteroposterior extent first. That means it is responding to treatment and it is improving. So EDI-OCT is very useful, and we see that choroidal granulomas heal in the anteroposterior direction first and then laterally. Now, in our study, we realized that there are a number of factors on which you can differentiate between TB and sarcoid. Of course, to differentiate between TB and sarcoid, you have to have your labs, your tuberculin skin test, and other evidence of active TB in the body, or even a healed lesion in the body. But we realized that a lot of eyes with TB have intense yellow granulomas, much more compared to those with sarcoidosis. In addition, shape is another important feature to differentiate between TB and sarcoid. A lot of patients of TB will have lobulated granulomas compared to oval granulomas in sarcoid. Many patients of TB also have macular granulomas, and they can be perivascular. A perivascular choroidal granuloma is highly characteristic of TB. We also realize that dull lesions are sarcoid, intense yellow are TB, and if you have pre-retinal hemorrhages, again, to reiterate, they are mostly seen in TB. OCT is very useful, and you can see that if there is presence of outer retinal hyperreflectivity, that goes in favor of TB, and I'll just show you on this slide. This is a patient with a large TB choroidal granuloma, and you realize that there is fuzziness of the outer retina with a breach of the RPE. And you can see this in some of the other slides. Along with intraretinal, there is subretinal fluid and outer retinal fuzziness. This outer retinal fuzziness or infiltration is highly characteristic of TB, and it can differentiate from sarcoidosis with a very significant p-value. Also, you see the panel above, this yellow lesion, like I showed you a previous patient, this is another patient who has subretinal fluid, an intense yellow lesion. And this lesion is a single large lesion suggestive of TB. The patient below shows you multiple hypo areas on ICG. Now you realize here, you don't see so much clinically, but on ICG, the pathology is so much evident. And that's why if you really want to study the choroid, OCT angiography, EDI-OCT, and ICG are the most important aspects. And you see these multiple choroidal granulomas, and this multiplicity goes in favor of sarcoidosis. So if you have multiple small lesions, highly characteristic of sarcoid. EDI-OCT again shows you a well-circumscribed oval lesion in the choroid with little amount of subretinal fluid. The exudation is much less compared to TB. And you can see here that the comparison shows you that the vascularization of the choroidal granuloma is much more in TB compared to sarcoidosis. The mean area of granuloma is so different. TB granulomas are large, they're more than 16 millimeters, but sarcoid ones are quite small. Now I'm going to show you another case of a young male with no previous history, spots in front of both eyes. And you can see here on ICG, there is hypofluorescence suggestive of flow deficit. The OCT shows you ellipsoid zone disruption and photoreceptor disruption. It's a large placoid lesion. And of course, there is no doubt in the diagnosis, this is an acute posterior multifocal pigmented lesion, which is involving the fundus here of the right eye. And if you look at the ICG and compare it with OCT angiography, you can see here that there is clear demarcation of the hypofluorescent areas on OCT angiography. There is no signal, flow deficit here. You can see there is no shadowing, no artifacts, and you can actually see the area much more clearly on OCT angiography. So this confirms that there is a choriocapillaritis. You have a placoid lesion which is involving the center. So OCT angiography shows you flow deficits in MPE, predominantly in the choriocapillaries. On the other hand, you have this lady, which is a 51-year-old Caucasian lady with blurriness and spots in front of the eye. On ICG, you have hypo lesions, which are distributed, much more prominent in the late phase. And these lesions are mudes, which are characteristically hypo to hypo on ICG, but sometimes they may be iso to hypo. What's interesting is the OCT, because here you have disruption of ellipsoid and it's extending to the outer retina. But you must see here on the OCT that the RPE is completely intact. The choriocapillaries also appear to be intact. And the most interesting aspect is, though you have hypo areas on ICG, you have absolutely no flow deficit areas on OCT angiography. So in mutes, there is no alteration on the OCT-A in choriocapillaries layer. And this is one very interesting finding, and that's why you can actually redefine the disease pathophysiology by using advanced choroidal imaging, like in this patient and in this disease, which is mutes. We now assume that mutes is most likely because of a primary pathology in the photoreceptors. It's probably a photoreceptoritis. And the changes on ICG are probably because of transient RPE damage causing this kind of a hypofluorescence. If you have a patient of mutes, this is another patient, which is a 38-year-old male. Very important findings are, contrasting findings on the blue autofluorescence, the BAF, and near infrared autofluorescence. You have hyper on one, which is the blue peak, and hypo on the near infrared. And this is so much different. So I use these imaging modalities, both of them very much in my clinics, to determine if the patient has mutes. This is a non-invasive quick imaging, which tells you that whether you should suspect mutes in your patient, especially if you have the blue peak autofluorescence. But we must remember there's nothing on OCT angiography as compared to ICG. So these patients are very different from your MPE, and therefore you must investigate these patients non-invasively and then determine if you'd like to go ahead with an ICG. So the learning lesson here is you have intact choriocapillaries in mutes. Now, choriocapillaries imaging is difficult because if you have eyes with uveitis, you know that your choriocapillaries layer can be quite irregular. It's not uniformly thick. And of course, the other issue is that you have errors because of shadowing. You can have a lesion which is hyper. Even the RPE can cause either back shadowing, like on your right side, there could be back shadowing, or there could be higher signal transmission, which is why you may not be able to see the choriocapillaries very well. Now, we've been working on building algorithms to determine the area or to quantify the choriocapillaries flow deficit in our patients. So we have developed sort of macros. You can use third-party software, quickly identify the flow deficit areas, and measure the area and actually quantify them. And this is very useful in pre-treatment and post-treatment analysis, which can tell you if the patient is improving or not. Now, this is a patient which has a flow deficit area in the choriocapillaries layer. And you see that first and the most important step is to subtract the superficial capillary plexus so that you remove all the vessels which are appearing from the superficial capillary plexus. You take it out and then you go ahead with your choriocapillaries analysis. And once you binarize, you have an effective area which can be measured. And you can use these imaging during the at baseline and follow-up. And you realize that you can actually look at the lesion if it's increasing in size or decreasing. So serial assessments is possible using various thresholding algorithms. There are standard steps such as standardizing the image, removing the projection artifact, and binarizing the image, and thresholds such as the Fansalkar's threshold. They work really well in analysis of the choroid. So there are a number of challenges such as non-uniformity of the choriocapillaries layer and projection and irregularity of RPE, all of which can be partly addressed. Some of the newer aspects which are upcoming include image compensation and multiple en-face image averaging, which can be very useful in the choroidal or choriocapillaries imaging. Finally, choroidal imaging is very useful in patients of VKH, and you can see that you have choriocapillaries flow deficit, which exactly co-localize with the ICG, and you can actually use the OCT angiography along with ICG or even without, especially if you're doing a serial follow-up, and OCT angiography may be very useful just to look at the dark dots, if they're increasing or decreasing in size, and you can taper the therapy accordingly. Thank you very much. Thank you, SOE, once again for this opportunity, and I'll be happy to take any questions. Thank you.
Thank you, Aniruddha. That was a very interesting talk. I'm sure there'll be questions at the end regarding some of the points you raised.